As we welcome everybody, we cannot forget our own Pitama of cardiology, Dr. Panchit Barua sir. I request ma'am to give a plural because sir has been our teacher. Sir has been here from the time of the inception of this institute. He's been my teacher, ma'am's teacher, and continues to be one of the best echocardiographers I know, showing me views in pediatric and adult cardiology, which I would never have imagined. As we launch this course, just a minute, because as ma'am and I eked out this course and planned this out, uh, what we have always envisaged is that line up there. You see that there is no student here who is us and who's not us. That was never the thing with Swami. All of you are our students. You need not have a tag of Satyasai. We have people like Anand, who is a part of the profession, part of the corporate world, and he's ready to guide us sit here all through the day and then discuss pacemakers. It doesn't happen that you have a galaxy sitting like this. Please take the best of this course. This is your course. We have written it. This is your course. You have to make the best of it. Ask questions. There'll be two moderators, but then all senior faculty will be guiding you. So all the best. We can start our first session right away.
As we've already heard, how significant our role is in diagnosing and in the diagnostic and the interventional field, and how constructive our learning should be, we move on to the first session of our today's scientific program. First up, we have clinical approach to understanding an echo. Understanding and performing echo is the very basic thing, very basic of our profession, right from getting crisp and clear images to diagnosing severity or quantifying the ejection fraction. We must understand the significance it holds in the prognosis and the management of the patient further. Performing an ultrasound, it is our sole responsibility to distinguish and to differentiate what needs immediate attention and as to what can be taken as the routine sonogram. One must also be aware of the various advancements and the change in guidelines and should always be updated. May I request Dr. Banjit Barua, sir, Senior Consultant, Department of Cardiology, to kindly moderate the session. We welcome you, sir. I'm honored to invite Dr. Banajit Barua, sir, Senior Consultant Cardiologist in Sri Satyasai Institute of Air Medical Sciences. Sir has completed his MBBS from Guwahati Medical College. Sir has done his internal medicine residency in Bronx Lebanon Hospital and Albert Einstein College of Medicine, New York. Sir has done both internal medicine and cardiology board certification from American Board of Internal Medicine, United States. Sir has been a clinical instructor of medicine in Rutgers Medical School, New Jersey, and Illinois University. Sir was also an assistant professor of cardiology in the University of Alabama. Sir was an examiner of Alabama Licensing Board and member of advisory council to ACC Garner, the state of Alabama. Sir has opened Selma Cardiology Center under the University of Alabama in July 1998. Presently, Sir is a senior consultant cardiologist in Sri Satyasai Institute of Biomedical Sciences, Bangalore. Welcome. Now I'm here to introduce the first speaker of this session. I'm very much honored to introduce such an eminent personality, Dr. Srikanth Sola, sir. Sir is an internationally reputed cardiologist. Sir holds an array of professional credentials, including MD, FACC, FAHA, and has acquired these qualifications from the finest institutions in the USA. Sir completed his undergraduate studies at Stanford University, residency training and internship in the medicine of Duke University Medical Center, and fellowship in cardiology at Emory University School of Medicine, Atlanta. Sir served as a staff cardiologist at the world-famous Cleveland Clinic in the USA. Sir is deeply involved in the academic activities and has authored many chapters in cardiology books, numerous journals, publications, and is involved in research projects nationally and internationally. Sir was named as one of America's top cardiologists by the Consumers Research Group of America in the year 2006-2007. Sir has won Rashtriya Gaurav Award by Indian International Fellowship Friendship Society, New Delhi, and Best Citizen of India Award by Best Citizen Publishing, New Delhi. Sir served as senior consultant in the Department of Cardiology at SSS IHMS Bangalore and instructor at SSS IHMS College of Allied Health Sciences. Currently, Sir is CEO and founder of Devic Earth Private Limited. We welcome you, sir.
Good morning, everyone. Am I audible? Yes, you can all hear me? Everyone's ready for an interactive session on echo? Yes or no? Yes or no? All right, let's begin. So what we're going to do today is go through the basics of echo in the sense of knobology. All those buttons and knobs that are on the machine, we're going to go through that today. Now tell me, when you start a echo test and your echo study, and you're not getting good images, what's the first thing that most people do? What's the first button that you turn to get better images? Okay, that's what I thought I was going to hear. Now let's go through how to actually get a good study. And it's all based on simple physics, simple principles that will help you to get a good image all the time. See, when you take a camera photo on your phone, do you just randomly snap or do you try to focus the image first? First you focus and then you take a picture, right? Who will take a picture that is blurred? No, someone will give you some nice patak and you will get made fun of. So first we're going to show you how to get a good image, because a good picture is worth 1,000 words. A bad picture is not worth much. So let's start with the Plax view. Okay. Now, typically when we start with the Plax view, the first view that I like to see in a study is like this. Why? Because I want to understand, is there a pleural effusion? Okay. Now, not everybody's going to have a pleural effusion, right? But this is generally the first view that I start with. It also helps me to get oriented to the heart. Now, once I do this, then I'm going to adjust the depth and then optimize my images. This is how I always start a basic transthoracic echo exam. For the purpose of today's presentation, we're going to focus on adult transthoracic echo images. Now, there's a couple of things you need to understand to help you understand where and when, how to make images better. The ultrasound beam is coming straight from the top. This is where the transducer is, right? Okay. And what happens when an ultrasound beam comes out of your transducer? It's going to come down, and it's either a few things are going to happen. One, it's going to reflect, right? And then it's going to bounce off and come back to your transducer. That's reflection. The other thing is it could have refraction. And the third thing is it could have attenuation. This is what happens to ultrasound beams, either reflection, refraction, or attenuation. By the way, what's the speed or velocity of ultrasound in tissue? How much? 1540 meters per second, right? That's a number you need to just memorize, 1540 meters per second. Now, what this means, though, if taking my image, look what's happening to this posterior pericardium. Do you think that the posterior pericardium is really so thick? Does this patient have CCP? No. What's happening here is that because your ultrasound beam is coming down like this, the beam is going to bounce off more, or we have better reflection from images or structures that are perpendicular to the ultrasound beam. Now, can you go? So that's why this posterior pericardium appears so thick in this image. Now, what this means from a practical standpoint, if you can we'll just clip this, and can you show the ascending aorta also? What this means from a practical standpoint is that your posterior pericardium is always going to appear a bit thicker. Now, why this is useful is because there's certain areas where you want to make measurements. So, for example, look at your ascending aorta here. See how this is perpendicular to your ultrasound beam, these lines of the ascending aorta? So when you make measurements of your ascending aorta, you're going to focus on your Plax view, right? You're not going to measure your ascending aorta from your apical 5-chamber window. Can you make a 5-chamber window for me? Why? Because when you get a 5-chamber view, notice the direction of the ultrasound beam. It's almost parallel to your ascending aorta, right? So when you're doing, so take advantage of this, understand that structures that are perpendicular to your ultrasound beam are going to appear brighter, more echogenic. So your ascending aorta is measured from your plaques view, not from your apical 5-chamber view. This also means that certain structures like the mitral valve, for example, are well visualized from the plaques view, as well as your 4-chamber views, because they're now perpendicular to the direction of your beam. So that's the first thing, is understanding how your ultrasound beam is made. Now, when you're taking pictures, there's a couple of things you want to remember. First is your gain. What does your gain do? It helps to increase how well your ultrasound transducer is hearing the reflection. It's like this. If I put my ears like this on my hands on my ears like this, I can hear better, right? So that's what gain does. It simply allows the transducer to hear better the ultrasound signals as they come back. But that's not that's like the last thing you want to adjust. Let's show you how better to do this first. Now, on the left side of every echo machine, you have these buttons that move left and right in a row. What are those called? Time gain compensation, right? TGC. Can you go to a 4-chamber view? So what you want to understand from the TGC is that it's not static, it's dynamic. So for example, let's take a look at this image here. If I wanted to image my pulmonary veins, right? Now my pulmonary veins are way down here, right? At the bottom of the image. Okay. So if I want to image my pulmonary veins, what's going to happen is as my transducer beam goes down farther away, or rather as the ultrasound beam goes farther away from my transducer, what happens is I get more attenuation. So I need to compensate for that because it's taking more time, because of more distance, for my ultrasound beam to come back. So what I'm going to do is at the bottom of my screen, I'm going to increase my TGC just a little bit. Now notice that if I increase it too much, I'm getting noise. What I want is for my LV cavity to be just slightly off black. Yeah, just slightly off black. And I can do this with my TGC as well as with my overall gain. So if I'm imaging something far away, I'm going to increase the TGC in the far field. This is your near field, okay? This is your midfield, and this is your far field. So when I'm imaging something in the 4-chamber view, whether it's apical 4-chamber, apical 2-chamber, apical 3-chamber, mainly in the apical 4-chamber, I'm going to increase TGC. Now let's say that this patient has heart failure, LV systolic dysfunction, okay? And now I want to look at the LV apex. Common thing, right? I want to rule out a thrombus. What I'm going to do is I'm going to reduce my TGC in the near field. If I don't, I get this thing here. What is this here? This is called near field noise. Can you see that on the image, how it's a little bit noisy? I'm going to make it even brighter on that. Now you can see it? Can you see how there's this white? It looks like a snowstorm here. Yeah, it's not very nice. Yes, so I'm going to reduce my TGC in the near field. Generally, the classic teaching is your TGC should be kept like a ski slope. It should be steep in the beginning, and then in the near field, it should flatten out. Okay, that's your time gain compensation. Now, there's a couple of other things you need to understand. Overall image quality is determined by what you do, but also what the patient does, okay? So let's go to this patient here. Now, he's a very cooperative patient, very friendly patient, but look at what's happening. When he breathes, what happens to the image? Can you take a small breath? What happens to the image, right? It goes away. So what you want to do is teach the patient how to cooperate with your exam. So what you're going to do is you're going to ask him to take a small breath in. Okay, breathe in slightly, breathe out slightly, and then hold it. And when he's holding his breath and end expiration, that's when you're going to acquire images. So let's ask him to do that. Small breath in, small breath out, hold it. Halka सांस लो, सांस ले लो, halka, 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 halka. Okay, so you have to coach them because otherwise they'll take a deep breath. So just a small breath in, small breath out, and hold it. Okay, now you can now see how the image goes out. Okay, halka, correct. बंद करो. Okay. Now you can see how you get much better image quality. Does that make sense? Yeah, you got it. Okay, so first thing is patient cooperation. Now this is good. Can you go to the 3-chamber view? So you typically have your patient in the left lateral decubitus, unless rarely you're doing a right parasternal view, parasternal view. That's uncommon. But you typically are going to have the patient like this. Now, how many of you in your echo labs have cutouts in your echo bed for the 3-chamber view? Anybody here in your hospitals? No, it's not very common. It sure would be nice. I'm going to teach you a simple cheat way to do this. So bring the patient to the edge of the bed. Okay, please don't let him fall off. Okay, bring the patient all the way to the edge of the bed. Okay, all the way, right? Now you put your arm like this so they don't fall off, so they know how far they can go. Bring them even more. I need them all the way to the edge of the bed. A little bit more right to the edge. Okay, now lean him back a little bit further away. Yes, now go for an apical 3-chamber view again. Okay, sure. Now look what happens when you keep your probe horizontal is that you're not able to see very well the ascending aorta. Can you appreciate that here? It's kind of seen, but not really, right? Now what I want you to do is to take your probe and tilt it down like this, okay? Take your probe and tilt it down. Can you see how that opens up the ascent? Now just try to open this up, and you're gonna have to rotate your probe just a little bit to get that ascending aorta. It also helps if you ask the patient to turn off their mobile phone during the exam. Okay, so what you do is so did everyone catch this? You bring the patient to the edge of the bed. Okay, please don't let them fall off because what you'll say is that Dr. Sola told me to do this and that's why the patient fell off the bed. Don't do that. Okay, bring the patient all the way to the edge of the bed. Now you need to bring your probe down. Most of you, when you do your 3-chamber view, your probe is horizontal. That's not correct, okay? For a proper apical 3-chamber view, your probe has to be tilting down like this, okay? That will open up your ascending aorta. This is especially crucial for aortic stenosis, subvalvular stenosis, supravalvular stenosis, aortic regurgitation, HOCM, where you're measuring LVOT gradients. You need to bring your probe all the way down, really tilt it down, really tilt it down, down, down. So you're going to bring your probe like this, okay? Like that. That's what I want to see. So you may have to bring him over, have him come into a hard APS. See? Yes, exactly. Can you see how that opens up the ascending aorta? This is a simple trick that you can do. So for patient cooperation, number 1, breath held in and expiration when you are recording your images. Number 2, for the apical 3-chamber view, you need to take your probe. Don't image like this, which is what most of you do. Your probe is held horizontally. Bring the end of your probe down. Let's say that the chest is here. Bring the end of your probe down so that you're imaging up the ascending aorta, and you might have to just slightly rotate clockwise to open up the ascending aorta. Simple tip that you can do to get better apical 3-chamber views. Okay, so this is patient positioning. Now let's go on to a few more things. You understand about TGC. You understand why I feel that gain is the last thing you should do. Then what should you do? It depends on what you're trying to understand. Can you go to a plaques view, please? Okay, now let's say that I'm doing a stress echo, okay? In a stress echo, do I want to see the mitral valve, the LA, or the LV? I want to see the LV, right? So what I'll do is exactly a view just like this, where I'm seeing more of the LV and less of the LA, right? Okay, can you go to an apical 4-chamber view? Okay, now if I'm doing a stress echo, this is good for regular transthoracic, right? This is how I'll typically start. I'll show LV function, RV function, LA, RA size, and so forth. Then when I want to show the mitral valve, what I'll do is I'll reduce the depth, and then I'll do my 2D in color. So what I'll do is I'll place my color flow Doppler here, and then I'll put it on simultaneous, and then I will record this image, right? Good. If I'll do the same thing for the tricuspid valve as well, and I'll do focus on the trach. Now bring for the 4-chamber view of the RV, bring the RV into the middle. I don't want to see the LV. So if I'm focusing on the RV, bring the RV into the center of the image. Yeah, just bring it over just a little bit more to the side. Focus on that RV. And of course, you're going to work with the patient for breath held and end expiration and so forth, but you're going to focus more on the RV. Now, notice that rib shadow that's coming here. So you want to get that out of the way. So according to your requirements, you're going to focus. Now, look at this though. Okay. I want to optimize a couple of things, right? First thing is, what's this thing at the top? What does FPS mean at the very top? What is that? I don't know if it's not shown here on your screen. I'm sorry, it's cut off. Okay, so not shown on your screen is something called frames per second. Frames per second. Frames per second is temporal resolution. Okay, when would I want to image something at a high temporal resolution? Maybe when I'm doing stress echo. Yes, maybe when I'm looking at something that's moving fast, like a papilloma, or systolic anterior motion of the mitral valve and HOCM. That's when I would want to do have a higher temporal resolution. When would I want to have higher spatial resolution, do you think? What clinical scenarios would I want better spatial resolution? When I'm looking for endocarditis, something small, right? When I'm looking for thrombus. So when you're looking for small things, you want higher spatial resolution. When you're looking for fast moving things, you want higher temporal resolution. So how do I change my temporal or spatial resolution based on what I'm looking at? One thing you can do is adjust your zoom. Now, because this so let's say I want to focus on the mitral valve. I'm worried about endocarditis. Okay, I would adjust the zoom and that will help me to get better spatial resolution. Okay, got it? So zoom, increase spatial resolution. Fine. Okay, a second thing I can do if I want to adjust my spatial resolution is I can look at my transducer frequency. Tell me how this works, the transducer frequency. Now, this is a transthoracic probe. The number is not shown on the screen, but this is about 1.4 and 2.8 megahertz. Most adult probes are between 2 to 5 megahertz. Pediatric probes are between 5 to 8 megahertz. So I can adjust my transducer frequency simply by changing the frequency on my probe. When would I do that, do you think? Has to be interactive. Let's say I want to do the apical, let's say I want to focus on the apex. Suppose this patient has a LV systolic dysfunction. I'm looking for a thrombus. What would I set my transducer frequency? I want it to be high, low, or medium? What do you think? High, low, or medium transducer frequency. I'm looking for an LV apical thrombus. What do I want? High, low, or medium transducer frequency. What happens to transducer frequency to spatial resolution as frequency goes up? Spatial resolution goes up with higher transducer frequency, right? So if I want to see something small in this LV apex, I want a high transducer frequency. So what I do is I just go to my machine setting and I increase the transducer frequency. Okay, got it. Understand? Okay. Now suppose, though, that I want to see something that's far away, like the posterior LA wall. Suppose that I'm concerned there's a thrombus, or suppose there's a mass in the posterior right atrium. And I'm concerned that I want to take a closer look at that. What would my transducer frequency be then? I'm looking at something far away. Will my frequency be high, low, or medium? It'll be low, right? Right? Because the lower transducer frequencies allows me to see far. The higher the transducer frequency, the better the spatial resolution, the more the attenuation. So high transducer frequencies don't allow me to see depth. That's why in pediatric patients, we're able to use transducer frequencies as high as 8 megahertz, but that would be impossible in an adult patient because we simply don't have that space, that much range. Okay, but if I want to see something way down here at the bottom of my screen, I want a low transducer frequency. Got it? Okay, so you understand how dynamic the exam is. You're adjusting your frequency, you're adjusting your depth. Now, suppose, let's go back to this case here. This is a new machine, so this doesn't have something called a focus. What does the focus do? Any idea? We talked about spatial resolution, right? So transducer frequency is one of the most important determinants of spatial resolution. In spatial resolution, you have something called axial resolution. Axial resolution means in the same line, what's your ability to distinguish two separate objects? That's axial resolution, okay? Then you have lateral resolution. Lateral resolution means in this same arc, what's my ability to see two images that are lying side by side? That's called lateral resolution. Where I have my focus, usually it's shown as a line here, is where I will have the best lateral resolution. Why? Because the normal ultrasound beam is hourglass shaped. And where that narrow part of the hourglass is, that's where the focus is. Okay? So having said that, if I'm looking at the LV apex in a patient with a suspected LV apical thrombus because of LV systolic dysfunction, what am I going to do to my focus? Where am I going to place it? Right here, no? Yeah. If I'm looking at the mitral valve, where's my focus going to be? It's going to be right here on the mitral valve. If I'm looking at the posterior LA because of thrombus or mass or something, or I'm looking at the pulmonary valve because I want to do PW of the pulmonary valve, where's my focus going to be? It's going to be way down at the bottom. Got it. Okay. So your focus is always going to be what you're looking at. Can you go to the parasternal short axis view? Bring him a bit more to the side. Yeah.
Dr. Srikanth, we are 6 minutes over.
Sure. So if I go to the parasternal long axis view, sorry, long axis view, then I want my focus to be here. Got it? Okay. So in this short presentation, you've understand several crucial things. Please don't reach just for the gain. Think about what you're trying to adjust. Optimize your depth, optimize your focus, optimize your transducer frequency, right? We haven't even touched on things like sector width, but optimize your sector width according to the structure that you are imaging. If you do these things, you will have a beautiful picture, and a beautiful picture really is worth 1,000 words. Thank you.
Thank you, sir, for practically demonstrating the basics of echocardiography.